Welcome to MBBS Mastery. In this video, we'll discuss gynecology, developmental, and hormonal disorders. Make sure to subscribe and hit the bell icon so you don't miss out on upcoming lectures. Did you know that the first sign of puberty in girls can start as early as 8 years old? But what actually triggers this entire transformation? Let's understand normal puberty from the ground up. Let me start with the basics of how puberty actually begins. First, understand this. Genetic sex is determined at fertilization. The moment the sperm meets the egg, the sex chromosomes decide whether the baby will be male or female. This is controlled by the sex chromosomes, XX for female, XY for male. But the interesting part is brain sex comes next. This refers to cerebral differentiation. The brain develops either a male or a female orientation. This happens during fetal development itself. Now, let's talk about something very important: childhood and the HPO axis. During childhood, the HPO axis is suppressed. What is the HPO axis? It stands for hypothalamus-pituitary-ovarian axis. This is the hormonal system that controls reproduction. In childhood, levels of GnRH, FSH, and LH are very low. These are the key hormones. GnRH is gonadotropin-releasing hormone. FSH is follicle-stimulating hormone. LH is luteinizing hormone. All of them stay quiet during childhood. But something amazing happens between 8 to 9 years of age. GnRH starts being secreted in a pulsatile manner. This means it's released in pulses, not continuously. This pulsatile secretion is the key. It's like turning on a switch. When GnRH is released, it stimulates FSH and LH. And when FSH and LH increase, they trigger follicular growth and steroidogenesis in the ovary. Steroidogenesis means production of sex hormones, mainly estrogen. Now here comes the star of the show: estrogen. The estrogen produced by the ovary then initiates the physical changes of puberty. This is the hormone responsible for all the visible transformations. Let me explain the physical changes one by one. These are divided into 3 types: thalarcha, adrenarcha, and menarcha. Thalarcha means breast development. This is usually the very first sign of puberty in girls. Adrenarcha means growth of pubic and axillary hair. Axillary means armpit. So hair appears in the pubic region and underarms. Menarcha means the growth spurt and onset of menstruation. This is when the girl gets her first period. Now remember this important clinical point. The first physical signs of puberty are breast budding, and this occurs 2 to 3 years before menarche. So if a girl develops breast buds at age 9, she might get her first period around age 11 or 12. Speaking of menarche, the mean age is 12.5 years. But don't worry if it takes time. It may take up to 3 years before the menstrual cycle establishes a regular pattern. This is completely normal. Also, initial cycles are usually anovulatory. Anovulatory means no ovulation occurs. The periods happen, but no egg is released. They can be unpredictable and irregular in the beginning. Now let's talk about a very important classification system: Tanner's classification. This is how we medically assess puberty progression. Tanner divided the stages of development into 5 stages. These stages apply to both breast growth and pubic hair growth. Let me explain each stage clearly. Stage 1. Basal growth rate. No breast or pubic hair development. This is the prepubertal stage. Stage 2. Breast budding begins. Sparse, straight pubic hair appears along the medial border of labia majora. Medial border means the inner side of the outer lips of the vagina. Stage 3. Accelerated growth. Elevation of breast contour with loss of contour separation between breast and areola. The breast and the darker area around the nipple become one smooth curve. Coarse pubic hair starts spreading onto the mons pubis. Axillary hair also appears. Stage 4. Growth slowing. Areola forms a secondary mound. This means the areola projects above the level of the breast. Adult-like breast tissue is forming, but still limited to mons with no spread to inner thigh. Stage 5. No further increase in height. Adult breast contour is achieved. Adult pubic hair type and distribution to inner thigh. This is the final mature stage. This classification is extremely useful clinically. When you examine a patient, you can tell exactly which stage of puberty she's in. If breast development hasn't started by age 13, or if menarche hasn't occurred by age 15, we call this delayed puberty. This needs evaluation. Also remember, the sequence matters. Normally, it's breast development first, then pubic hair, then growth spurt, then menarche. If you see a different sequence like pubic hair before breast development, think about adrenal causes or other hormonal issues. One more thing. Estrogen causes breast development and growth of the uterus and vagina. But androgens from the adrenal gland cause pubic and axillary hair growth, so these two processes have different hormonal controls. Now, imagine a 6-year-old girl developing breasts and getting her periods, or a 16-year-old with no signs of puberty at all. These are real clinical scenarios, and now we're going to understand exactly what causes them and how to manage them. Let's discuss precocious puberty now. What does precocious mean? It means early, too early. So precocious puberty refers to the start of puberty before the age of 8 years in girls or 9 years in boys. Now, this is really important. It occurs in the active pubertal age. But what happens? It leads to early accelerated linear growth with premature epiphyseal closure. Let me break this down for you. Linear growth means the child grows tall quickly. But here's the problem. Premature epiphyseal closure. The epiphyses are the growth plates in bones. When they close early, growth stops. So these children initially grow fast, but they end up with restricted final height. They become short adults. Now, precocious puberty is divided into two major types, central and peripheral. Let's talk about central precocious puberty first. This is gonadotrophin dependent. Remember GnRH, FSH, and LH. These are gonadotrophins. In central precocious puberty, the entire HPO axis activates early. The brain starts releasing GnRH too soon. What causes it? It is caused by CNS malformations and tumors. CNS means central nervous system, the brain and spinal cord. Sometimes tumors or structural problems in the brain trigger early GnRH release. Now let's look at peripheral precocious puberty. This is gonadotrophin independent. The brain and pituitary are not involved. The problem is elsewhere. What are the causes? Let me list them clearly. First cause, primary hypothyroidism. When the thyroid gland doesn't produce enough thyroid hormone, it can paradoxically trigger early puberty. This seems strange, but it happens. Second cause, estrogen-secreting ovarian cysts. Sometimes the ovary develops cysts that produce estrogen on their own, without any signal from the brain. Third cause, late onset. CAH. CAH stands for congenital adrenal hyperplasia. In this condition, the adrenal glands produce excess androgens. Late onset means it shows up later in childhood, not at birth. Now let's move to delayed puberty. This refers to absence of signs of secondary sexual characteristics by the age of 14 years. If by age 14 there's no breast development, no pubic hair, nothing, that's delayed puberty. Delayed puberty is also divided into two types, central and peripheral. Central, hypogonadotropic hypogonadism. This is characterized by conditions affecting the central nervous system. The problem is in the brain or pituitary. GnRH, FSH, or LH are not being released properly. It is characterized by low GnRH, FSH, and LH, and therefore decreased estrogen. No signal from the brain means no stimulation of the ovaries. No estrogen production. It is associated with delayed puberty and primary amenorrhea. Primary amenorrhea means the girl has never had a period by age 15 or 16. What are the causes? Let me explain each one. Constitutional. This means familial or genetic. It runs in families. The girl is perfectly normal, just a late bloomer. This is the most common cause. Excessive exercise. Athletes, especially gymnasts and runners, can have delayed puberty. Too much exercise suppresses the HPO axis. Chronic illness, conditions like renal failure, diabetes, or malnutrition can delay puberty. The body focuses on survival, not reproduction. Pituitary diseases, adenomas, tumors, or Sheehan syndrome. Sheehan syndrome happens when the pituitary gland dies due to severe bleeding during childbirth. But in adolescence, think more about tumors. Kallmann syndrome. It is caused by deficiency of GnRH. Without GnRH, the pituitary can't release FSH and LH. Without FSH and LH, puberty never starts. It presents with delayed puberty and impaired sense of smell. The smell problem is called anosmia or hyposmia. This combination, no puberty plus no sense of smell, that's Kallmann syndrome. Now, peripheral, hypergonadotropic hypogonadism. This is also called gonadal failure. Here, the brain is working perfectly. GnRH, FSH, and LH are all high or normal. The pituitary is screaming at the ovaries to work, but the ovaries don't respond. That's why it's called hypergonadotropic, high gonadotrophins. Low estrogens, but high levels of GnRH, FSH, and LH. The feedback system is trying to compensate but failing. It can cause ovarian failure at any age and can therefore present as primary or secondary amenorrhea. Primary means never had periods. Secondary means periods stopped after starting. Let me explain the causes. First, ovarian failure from various reasons like chemotherapy or radiation. Cancer treatments can damage the ovaries permanently. Second, primary amenorrhea with delayed puberty. The ovaries never worked from the beginning. Third, secondary amenorrhea with normal sexual development. The girl went through puberty normally, had periods, then they stopped. This suggests the ovaries failed later in life. Now let's look at the treatment. First phase. It is for induction of puberty. Puberty won't start on its own, so we induce it artificially. It involves hormone replacement therapy. We give estrogen at low doses. We start with very low-dose estrogen. Progesterone is introduced after 18 months to 2 years of therapy. Why wait? Because we want to mimic natural puberty. In natural puberty, estrogen comes first, then progesterone comes when periods start. The goal is to give the body time to develop breasts, uterus, and other secondary sexual characteristics before introducing periods. Second phase. It is given when the woman desires pregnancy. Remember, most women with Turner syndrome cannot get pregnant naturally. Their ovaries don't work. It can only be achieved with the aid of a donor egg. The woman receives an egg from another woman, which is fertilized with sperm, and then implanted in her uterus. Pregnancy progresses normally thereafter. With modern medicine, pregnancy outcomes are usually good. Childbirth may be difficult due to short stature. I'll give a clinical approach for you. When you see a child with early puberty, always check. Is it central or peripheral? How do you check? Do a GnRH stimulation test. If FSH and LH rise after giving GnRH, it's central. If they don't rise much, it's peripheral. For delayed puberty, measure FSH and LH. If low, think central, brain problem. If high, think peripheral, ovary problem. Also remember, girls with precocious puberty need bone age x-rays. We x-ray the left hand and wrist. The bones show how old the skeleton is compared to chronological age. In precocious puberty, bone age is advanced. One more thing. In central precocious puberty, we can use GnRH agonists as treatment. These medicines initially stimulate, but then suppress the HPO axis. They pause puberty until the appropriate age. What if I told you there's a condition where a girl has only one X chromosome instead of 2, and this single missing chromosome affects her entire life, from her height to her heart to her ability to have children? Let's discuss Turner syndrome. This is absolutely crucial for your exams and clinical practice. First, the basic introduction. Turner syndrome is also known as monosomy X. Monosomy means only one copy of a chromosome instead of two. So instead of having XX chromosomes like normal females, these girls have only one X. That's why we call it 45XO. The O represents the missing chromosome. Now, here's a very important exam point. Turner syndrome is the most common cause of primary amenorrhea in women. Primary amenorrhea means a girl has never had her periods even by age 15 or 16. If you see primary amenorrhea in an exam question, always think of Turner syndrome first. Now, let's understand when this syndrome appears. It presents at two ages in life, either soon after birth or at a time of delayed puberty. Why two different times? Because some features are visible at birth, while others only become apparent when puberty should start but doesn't. The syndrome is diagnosed by looking at the karyotype. A karyotype is a picture of all the chromosomes. In Turner syndrome, the karyotype shows 45XO instead of the normal 46XX. Let me explain the phenotype and genotype. The phenotype is female. These individuals look like girls. The genotype also shows female because there's no Y chromosome. The incidence is 1 in 2,500 live births, so it's not extremely rare. You will see these patients. Now comes the pathophysiology. Pay close attention because this explains everything. The undifferentiated gonad will develop into an ovary due to absence of Y chromosome. Remember, if there's no Y chromosome, no testis-determining factor is present, so by default, the gonad becomes an ovary. But the problem is, due to presence of only one X chromosome, there will be failure of development of oocytes. Oocytes are the eggs. The ovary forms, but it has no eggs inside. This results in streak ovary. A streak ovary is a non-functional ovary. It looks like a thin streak of tissue instead of a normal ovary. It produces no hormones, no eggs, nothing. The absence of a functional ovary means there is no estrogen production at puberty. No estrogen means no secondary sexual characteristics can develop. No breast development, no periods, nothing. And importantly, secondary sexual characteristics cannot develop. These girls enter the age of puberty, but nothing happens. This is why they present with delayed puberty and primary amenorrhea. Due to absence of MIF, Mullerian inhibiting factor, the paramesonephric duct will differentiate into various structures. Let me explain this step by step. MIF is produced by testis. Since there's no testis here, there's no MIF. When MIF is absent, the Mullerian ducts develop freely. What do they develop into? The Mullerian ducts form the uterus, fallopian tubes, cervix, and vagina. So these structures are present in Turner syndrome girls. This is really important. They have a uterus, they have a vagina. The internal genitalia are female and present. Now the signs and symptoms of Turner syndrome. This is extremely high yield for exams. First main feature, absence of secondary sexual development. No breast development, no pubic hair, no periods. We've already discussed why. No ovarian function, no estrogen. Second, primary amenorrhea. They never get periods naturally. This is one of the cardinal features. Third, primary infertility. They cannot get pregnant naturally because they have no functional eggs in their ovaries. Fourth, normal intelligence. This is important. Unlike some other chromosomal disorders, these girls have completely normal IQ. They can study, work, live independently. Fifth, edema of hands and feet. You might see swelling in the hands and feet, especially in newborns. This is due to lymphatic problems. Sixth, webbed neck. This is a classic finding. The neck has extra skin folds on both sides, giving a webbed appearance, like the webbing between fingers. Seventh, wide carrying angle. When they stand with arms at their sides, the arms angle outward more than normal. This is called cubitus valgus. Eighth, broad chest with widely spaced nipples. The chest looks broader than normal, and the nipples are farther apart than usual. Ninth, short stature. This is one of the main features. Turner syndrome girls are short. This is the main feature of a growing child. If you see a short girl with no signs of puberty, think Turner syndrome immediately. It is this feature that suggests to the clinician the possibility of a sex chromosome anomaly. Now let's look at associated features. These are other medical problems that come with Turner syndrome. First, coarctation of the aorta. The aorta is the main blood vessel from the heart. Coarctation means narrowing. So there's a narrowing of the aorta, which can cause high blood pressure. Second, inflammatory bowel disease, IBD. These patients have a higher risk of conditions like Crohn's disease or ulcerative colitis. Third, deafness, both conductive and sensorineural. They can have hearing problems. Conductive means problem with the ear canal or middle ear. Sensorineural means problem with the inner ear or nerve. Fourth, short metatarsals. The metatarsals are the long bones in the feet. In Turner syndrome, they're shorter than normal. Fifth, autoimmune thyroid disease. They're at high risk for thyroid problems, especially Hashimoto's thyroiditis. Renal cystic disease. Yes, kidney abnormalities are also common. Now, the investigation and treatment. How do we investigate a suspected case of Turner syndrome? First investigation, clinical examination. Look for all the features we discussed: short stature, webbed neck, wide carrying angle, shield chest, etc. Second, karyotyping. This is the gold standard. We look at the chromosomes. The karyotyping is typically 45XO. This confirms the diagnosis. Third, measurement of FSH and LH, which are markedly elevated. Why elevated? Because the pituitary is trying desperately to stimulate the non-functional ovaries. High FSH and LH with low estrogen equals hypergonadotropic hypogonadism. Now, the treatment. This has two phases as we discussed briefly before. First phase, for induction of puberty. We use hormone replacement therapy, HRT. We start estrogen administration at low doses to mimic natural puberty gradually. Progesterone is introduced after 18 months to 2 years of therapy. This sequence mimics normal puberty. Estrogen first for development, then progesterone to establish periods. Second phase, when the woman desires pregnancy. Here's the reality. Natural pregnancy is almost impossible because there are no eggs. It can only be achieved with aid of a donor egg. Another woman donates her egg, it's fertilized in the lab, and implanted in the Turner syndrome woman's uterus. Pregnancy progresses normally thereafter. The uterus works fine. Remember, the uterus is present and can function with hormone support. Childbirth may be difficult due to short stature. Shorter women have smaller pelvises, which can make vaginal delivery challenging, but cesarean section is always available. Psychological support. Yes, these women need psychological counseling and support throughout their lives. Also remember, growth hormone therapy is often given to Turner syndrome girls during childhood to help them grow taller. It doesn't cure the short stature completely, but it helps them gain a few extra inches. Screen all Turner syndrome patients for heart defects, especially coarctation of aorta and bicuspid aortic valve. These are potentially life-threatening if missed. And regularly check their thyroid function. Autoimmune thyroid disease is very common in these patients. One interesting genetic fact: about 50% have the classic 45XO karyotype. The other 50% have mosaic patterns, meaning some cells have 45XO while others might have 46XX or other combinations. Mosaicism can lead to milder features. Remember this exam tip. Short stature plus primary amenorrhea equals think Turner syndrome first. A 16-year-old girl comes to you with primary amenorrhea. She looks completely normal. Her breasts are developed, she has normal body hair, but she's never had a period. You examine her and find that 2/3 of her vagina is simply missing. This is Mullerian agenesis, and it's more common than you think. Let's dive into Mullerian agenesis, also known as Rokitansky syndrome. Now, what is this condition? It is due to the absence of the development of the Mullerian paramesomniphric system. Let me explain the embryology briefly. During fetal development, there are two duct systems, Wolffian ducts and Mullerian ducts. In females, the Mullerian ducts normally develop into the uterus, fallopian tubes, cervix, and upper two-thirds of the vagina. In Mullerian agenesis, these ducts simply fail to develop properly. They either don't form at all or they form incompletely. Etiology equals idiopathic, multifactorial. Idiopathic means we don't know the exact cause. Multifactorial means multiple factors, genetic, environmental, perhaps others, probably play a role. It's not a simple single gene disorder. Now let me explain each feature clearly. There is absence of the uterus and upper two-thirds of vagina, while the ovaries function normally. This is the key anatomical finding. No uterus, no upper vagina. But, and this is critical, the ovaries are completely normal. They're there, they work, they produce hormones. Why are the ovaries normal? Because ovaries don't develop from Mullerian ducts. They develop from a different embryological structure. So Mullerian agenesis doesn't affect them at all. The vagina is blind-ending and shortened. So there is a vagina, but it's very short. It ends blindly, there's no cervix, no connection to a uterus, because there is no uterus. This short vagina is actually formed from the urogenital sinus, not from Mullerian ducts. That's why it's present. How do these patients present clinically? First, primary amenorrhea, second most common cause after Turner syndrome. This is a crucial exam point. If you're asked about causes of primary amenorrhea, the top two are Turner syndrome, most common. Mullerian agenesis, second most common. Second, normal secondary sexual characteristics. These girls go through puberty completely normally. Breast development, normal. Pubic and axillary hair, normal. Body proportions, normal. Everything looks normal. Why? Because the ovaries work normally, producing estrogen. Estrogen drives all these secondary sexual characteristics. Ultrasound is often the first imaging test. You'll see two normal ovaries on the scan, but no uterus. The uterus is simply absent. This is shocking for patients and families when they first hear it. How do we manage these patients? First, surgical creation, elongation, of vagina. The existing short vagina needs to be lengthened. There are several surgical techniques for this. Second, psychological support. This is absolutely essential. Imagine being a teenage girl and learning you can never carry a pregnancy. The psychological impact is enormous. These patients need counseling, support groups, and ongoing mental health care. Third, surrogacy, pregnancy by surrogacy. Here's how this works. The patient has functioning ovaries. Her eggs can be retrieved. They can be fertilized in vitro with her partner's sperm. The embryo is then implanted in a surrogate's uterus. The surrogate carries the pregnancy. This way, the baby is genetically the patient's own biological child, just carried by someone else. An alternative is IVF and uterus transplantation, which is an emerging option. Uterus transplantation is now possible in some specialized centers. A uterus from a donor, living or deceased, can be transplanted. The patient can then potentially carry her own pregnancy. This is still experimental but very promising. Now let's move to Mullerian obstruction. This is different from Mullerian agenesis. Here, the Mullerian structures are present, but they're blocked. It is due to failure of complete canalization of the Mullerian structures. Let me explain. During development, the Mullerian ducts form as solid cords, then they hollow out, canalize, to become tubes and cavities. If this canalization fails, you get obstruction. It leads to menstrual obstruction most commonly at the junction of the lower third of the vagina at the level of the hymen. So the most common site of blockage is at the hymen, the membrane at the vaginal entrance, imperforate hymen. What does imperforate mean? It means no opening. A normal hymen has an opening that allows menstrual blood to flow out. An imperforate hymen is completely closed, no opening at all. It is the simplest form of obstructive problems. This is the easiest type to diagnose and treat. It presents with cyclical abdominal pain in adolescent girl. A 13 or 14-year-old girl develops severe lower abdominal pain every month. The pain comes like clockwork, same time each month, lasts a few days, then goes away. Why? Because she is having periods. Her ovaries work, her uterus works, menstrual blood is produced. But it cannot flow out. It accumulates behind the imperforate hymen, causing pain and pressure. On genital examination, bluish bulging membrane is visible at introitus. This is the classic finding. When you examine the perineum, you see the hymen bulging outward. It looks bluish or purple because there's menstrual blood trapped behind it. The bluish color is the blood showing through the thin membrane. This is called a blue bulge. It causes hematocolpos, blood-filled dilated vagina due to obstruction. Hemato means blood. Kolpos means vagina. So hematocolpos literally means blood in vagina. The vagina fills up with menstrual blood month after month and becomes distended like a balloon. It causes hematometra. Hematometra means blood in the uterus. The uterine cavity also fills with trapped menstrual blood. If left untreated long enough, the blood can even back up into the fallopian tubes. This is called hematossalpinx, blood in tubes. Treatment equals surgical incision of the hymen and drainage of blood. The treatment is simple. Make an incision in the hymen, drain the accumulated blood, and done. The problem is solved. After the hymenal incision, the girl will have normal periods flowing out normally. She can have normal fertility. Complete cure with a simple procedure. Sometimes the first presentation is acute urinary retention. Why? Because the distended blood-filled vagina presses on the urethra and bladder, preventing urination. This is a surgical emergency. The procedure is called hymenectomy or hymenotomy. It's done under anesthesia. Make a cruciate, cross-shaped incision in the hymen. Drain the blood. Sometimes liters of old menstrual blood come out. The relief is immediate. Types of Mullerian obstruction. Besides imperforate hymen, there are other obstructive anomalies. Transverse vaginal septum. A wall of tissue across the vagina. Cervical agenesis. No cervix, blocking flow from uterus. Vaginal agenesis with functioning uterus. Rare combination. Each requires different surgical approach. And that brings us to the end of today's comprehensive session on developmental and hormonal disorders. Let me quickly recap what we've covered today. We started with normal puberty and Tanner staging. Understanding how puberty normally progresses is essential to identify abnormalities. Then we explored precocious puberty and delayed puberty, both central and peripheral causes, and how to distinguish between them. We discussed Turner syndrome in detail, the most common cause of primary amenorrhea, with its characteristic features of short stature, streak ovaries, and absent secondary sexual characteristics. We discussed Mullerian agenesis, or MRKH syndrome, the second most common cause of primary amenorrhea, and Mullerian obstruction, particularly imperforate hymen. These are high-yield topics for your exams and absolutely crucial for clinical practice. Understanding the hormonal pathways, knowing how to investigate, and being able to counsel patients sensitively are skills you'll use throughout your medical career. This concludes our today's video on developmental and hormonal disorders. If you found this video helpful, please hit that like button. It really helps the channel grow and reach more medical students like you. Subscribe to MBBS Mastery and press the bell icon so you never miss any video. We're building a complete library of high-yield medical education content just for you. Drop your questions, doubts, or exam experiences in the comments below. I read every single comment and try to answer as many as possible. Your questions also help me create better videos. Share this video with your batchmates, junior doctors, and anyone preparing for medical exams. Knowledge grows when shared. Our next video will be on disorders of menstrual cycle,